So the last formal presentation for this launch will be a presentation entitled Methods for Estimating Quality Adjusted Coverage. That will be given by Melinda Munos, who's the PI for Improving Coverage Measurement and who was introduced earlier this morning.
Thanks, Cindy. And I know we've been listening to lots of presentations. This is the last one before we can have some discussion. So I will try to be quick, but we did want to talk about these methods for linking household and facility data. And thank you to Harry in particular for promoting sort of the need for these methods. So I want to note that what I'm going to be presenting now is the results of two different studies that were collaborations between NCA in Côte d'Ivoire, Chainama College in Zambia, Tulane, and Johns Hopkins. So I'm presenting on behalf of a large group of people here. A couple of definitions first. So we've talked about coverage. I'm also going to talk about quality here. So structural quality we define as, it's also known as readiness, which is basically the environment at a health facility, infrastructure, human resources, and commodities. Process quality is the quality of the actual provision of care to patients in the facility. And we're defining quality adjusted coverage as the proportion of individuals in need of a service or intervention who receive that intervention from a health facility that has high service quality. So when we think about how do we do this? How do we link household and health facility data? There are two general approaches. The first, and what is considered more of the gold standard approach, is called exact match linking. And the idea here is that you link care-seeking episodes in the household survey to information about the specific provider that was visiting during a care-seeking episode. So if a woman reports that she delivered at a particular first-level health facility, you go and you get information on the quality of services at that health facility, and you assign that quality score to the care-seeking episode. This is very difficult to do because it requires, in household surveys, collecting data about which specific facilities were visited, the names of facilities, which is not straightforward. It also requires you to have data about quality of care data about essentially all providers. Ecological linking is an easier way to do this. And here you link care-seeking episodes in household survey to some average quality of care score that could be calculated within a geographic area, within a type of provider, within a certain radius of the cluster, the household survey cluster, or you could assign the quality score for the nearest provider. So there's a variety of ways of doing this, but ecological linking aims to get around this issue of having to know exactly where people sought care and having to have data on all health facilities. And so what we wanted to do, what Improve has sought, or what ICM sought to do, is to understand what is the feasibility of doing this, both exact match and ecological linking, and also whether estimates produced by these more feasible ecological linking methods are essentially equivalent to exact match estimates. So we did this in two settings. We did a pilot study in Zambia that was nested within the care-seeking validation study that you just heard about. And in Côte d'Ivoire, we implemented this study in one region, in the Savane region of Côte d'Ivoire. The Zambia study was focused on sick child care specifically, and the Côte d'Ivoire study looked at a variety of services from ANC all the way through to sick child care. Both studies conducted a census of facility and non-facility providers in the study area to allow us to do the exact match linking. And in Zambia, we conducted our own household survey. In Côte d'Ivoire, we collaborated with the mix, the 2016 mix there. They kindly agreed to add questions on the identity, the name of the health facility that was visited during care-seeking episodes that women reported. And then in both settings, we used both exact match linking and then a variety of different ecological linking methods that had been proposed by various researchers in the past. So in terms of the data analysis, each care-seeking episode in the household survey was assigned structure and process quality scores using both exact match and ecological approaches, and we compared those scores. We compared the resulting estimates of coverage. If multiple providers were visited, which was relatively uncommon outside of ANC, the quality scores of those providers were averaged. If somebody needed to seek care but did not seek care, for example, if a woman delivered at home, they got a score of 0. Obviously, if they sought care from an unqualified provider, in Côte d'Ivoire, we assigned them a score of 0. In Zambia, we actually collected quality data from traditional healers, so they got whatever the score was that traditional healer had. And for ecological methods that involved computing a mean quality score across a number of facilities, we weighted those mean scores by service-specific caseload, so by the facility caseload. And we did some sensitivity analyses looking at the effect of facility weighting and the effect of including only public sector facilities. So we found that doing exact match linking is feasible but resource intensive, which I think is not surprising, but we were happy. So in Zambia, we were able to link 99% of children in rural areas and 93% in urban areas to the named provider. So we had data on the provider that they said that they went to. In Côte d'Ivoire, we were able to link 93% of care-seeking episodes to the named provider, and that was similar across service areas, more or less. So in terms of the comparability of the exact match and ecological estimates, this table is complicated, but essentially the top row that is bolded shows the exact match, the quality adjusted coverage estimate generated using exact match methods, and all of the rows below that show different ecological methods. And what we found in Zambia was that ecological methods produced measures of quality adjusted coverage that were quite close to the exact match methods, with the exception of the kernel density estimation method, the KDE method that you see at the very bottom. The kernel density method really overestimated the exact match method by quite a bit in urban areas, significantly so, and underestimated the exact match methods in rural areas. But in terms of the other ecological linking methods, they were not there. The estimates that they produced were not significantly different from the exact match estimates. This slide shows some of the results from Côte d'Ivoire. This is a complicated figure because we're trying to summarize a lot of data. But the y-axis here is the relative difference, or the percent difference, between exact match and ecological linking methods. And then each sort of set of points along the x-axis represents a different ecological method. The colors of the dots represent the service area. So basically, there's two things that I want you to note here. One is that for many of these methods and service areas, the differences between exact match and ecological linking were relatively small and non-significant. So I don't have the significance here, but many of these differences were not significant. The exception was really child health, and I can talk about why that was. But the other thing that I want to note is that ecological methods that did not either adjust for provider type or weight by caseload tended to underestimate exact match methods. So those are those two sets of points that are circled in red. Those are examples of ecological methods that didn't weight or adjust by provider type. Methods that did either weight or consider provider type tended to be more evenly distributed around 0 in terms of their difference from the exact match approach. And the method that worked the best, or that was the most similar to the exact match approach, was the 10-kilometer buffer method. So basically, we drew a circle around the cluster with radius 10 kilometers, and we took an average of all of the health facilities in that circle and assigned that to the care-seeking episode, again, weighted by caseload. Okay. These studies did have some limitations. We used a relatively simple quality of care score, an unweighted average of items. Both of these settings have relatively straightforward care-seeking practices that are dominated by the public sector. There's not a lot of sequential care-seeking. There's not much use of the private sector. And so we do think these settings are generalizable to lots of other places in sub-Saharan Africa, but they are probably not generalizable to, large urban areas, probably a lot of South Asia as well. The Zambia study was a pilot study. It had a relatively small N. And we do want to note that our exact match estimates are also imperfect, right? We're treating this as the gold standard, but we weren't able to match or to link every single care-seeking episode, particularly in Côte d'Ivoire. So what can we conclude from this data? So absolute differences between exact match and ecological linking methods were small, generally less than about 5 percentage points. Adjustments for provider category and weighting by service-specific utilization tended to result in better agreement between exact match and ecological methods. There's another paper in the supplement that came out of the EQUIP project in Uganda that also found similar results, that adjusting for provider level improved ecological estimates. And so we are recommending that as a method going forward. So we do think that ecological linking is feasible and valid for estimating quality adjusted coverage when a census of providers is used. We need more research to assess the effect of having only a sample of facilities instead of a census, and we also need more work in other settings to understand how these methods perform in more complex care-seeking environments. And I just want to acknowledge all of our partners at the different institutions. So thank you.
Any questions for Melinda?
Since many of us use DHS and DHS clusters are modestly displaced, I was curious whether you all also displaced your clusters and tried the ecologic approach.
So we're actually doing that right now. Emily Carter, sitting in back, has been doing that analysis. So we had for the mix, we had undisplaced cluster locations, which was nice, and it also allows us now to simulate displacements and see how that affects each of these methods. So that's going to be coming.
Can you give us a preview?
Using household locations versus cluster locations makes a difference, and kind of the takeaway from that was it does not, that you're just as good using that kind of broader cluster location. We have not finished the displacement analysis. My prediction is that it's not going to have a significant effect.
And maybe also to note that displacement only affects some ecological methods. So ecological methods that are based on like taking an average of facilities within the region, say, wouldn't be affected by displacement because DHS doesn't displace outside the region. But nearest provider methods or like the 10K buffer method would be affected, yeah.
Another question?
You said child health got wonky. Can you speak to that a little bit?
Yeah. So actually, we think this is an artifact of us trying to be maybe too comprehensive in Côte d'Ivoire. So in Côte d'Ivoire, we included we included in our facility assessment non-facility providers, including community health workers and pharmacies, and those got quality scores, generally not good ones. The quality of care was not great from non-facility providers. But in fact, in the mix in Côte d'Ivoire, there was very little utilization of non-facility providers. Almost all sick kids got taken to a first-level public health facility. What that meant was that in the ecological linking methods, those pharmacies and CHWs were getting averaged in, right? So they were dragging the average provider score down. And so when we redid the analysis looking only at public sector providers, it worked a lot better for sick children because you weren't including these providers that really weren't being utilized and that had poor quality of care.